Okay, we're covering the endocrine system. We're going to start with the top of the body at the pituitary gland and work our way down. So we're going to start with pituitary gland. We have the posterior pituitary, where we store and release antidiuretic hormone and oxytocin, and the anterior pituitary, where we store and we actually make and release adrenocorticotropic hormone, thyroid stimulating hormone, and human growth hormone. Now, there are 3 additional hormones. We have FSH, LH, and prolactin. So that's good to know, especially for lecture at this point, but we'll look at those other 3 hormones when we get to the reproductive system. Right now, we're going to keep it down to these 3 from the anterior pituitary. Okay, so for each of these, we have negative feedback loops. Thyroid stimulating hormone. We have our stimulus, a decrease in T3, T4 levels or metabolic rate. We have our production site, which is the anterior pituitary gland. The target site are the follicular cells in the thyroid gland, and the action response is to release more T3, T4. Adrenocorticotropic hormone, the stimulus is decrease in cortisol levels or long-term stress. The production site is the adrenal cortex. The target site, is the the production site is the anterior pituitary gland, my bad. The target site is the adrenal cortex, and the action response is to stimulate more cortisol release or increase cortisol production and release. Sorry about that, you guys. I've got a cold right now. I don't know, or allergies or something, so I'm a little nasally sounding. All right, so these 2 hormones, thyroid stimulating hormone and adrenocorticotropic hormone, they are produced and released from the anterior pituitary. They are going to actually target another gland for it to release another hormone. Okay, so for thyroid stimulating hormone, the fluctuating levels of T3, T4 is primarily what will stimulate the release of thyroid stimulating hormone from the anterior pituitary to target the follicular cells in the thyroid gland, and they start producing T3, T4. And I described this in lecture as well. I said, when we get to the thyroid gland, we're going to look at T3, T4. We're going to go, okay, then what does it do? So adrenocorticotropic hormone is similar in that in varying levels of cortisol, the anterior pituitary releases adrenocorticotropic hormone. It targets the adrenal cortex, particular layer in there that produces for those cells, to target those cells that produce cortisol, and thus the cortisol level elevates. When we get to the adrenal gland, we'll look a little bit more about what cortisol does. Okay, then we have human growth hormone. Human growth hormone, the stimulus is decreased human growth hormone levels in blood. Sorry about that. Right, so as again, we have fluctuating levels of human growth hormone, we will secrete more from the anterior pituitary. Now, this isn't going to target necessarily another gland, but it will target general body cells. We kind of refer to it as. Right, so the production site is the anterior pituitary gland. Your target site, are bones, skeletal muscles, cartilage, liver, general body cells. Right? And its action response is to increase mitosis rate, increase protein synthesis, cellular repair, and increase blood glucose levels to a certain degree. Disorders. Pituitary dwarfism is a hyposecretion of human growth hormone in children or infants. Pituitary giantism is a hypersecretion of human growth hormone in children. And acromegaly is a hypersecretion of human growth hormone in adults. When it comes to some of these hormones, for instance, like especially human growth hormone, T3, T4, there be a few of them. I'm going to use specific language, so to speak, to help identify that particular hormone, because their functions start to become, instead of black and white, rather gray and shared by other hormones. For instance, another hormone that helps elevate blood glucose levels, is cortisol, and also glucagon from the pancreas. because it breaks down glycogen into its monomers. Right? So yes, to a certain extent, yes, human growth hormone is going to increase blood glucose levels, but it's not a big, it's not going to be the hormone that's released with varying levels of blood glucose. When you have high and low, above and below the normal glucose ranges, we primarily use insulin and glucagon. However, for human growth hormone to be effective and to stimulate all this protein synthesis and mitosis and so forth and cellular repair, it takes energy, right? So you're going to release some extra glucose into the blood because you're going to need it. Skeletal muscle is going to need it to repair the liver, the cartilage cells, bones, so forth. So it's not stimulated to be released, or the stimulus for release for human growth hormone is not varying levels of blood glucose. It's blood glucose release is a byproduct of human growth hormone because of all the active processes that will be taking place within a cell that's going to anticipate needing more ATP, made by the mitochondria. Okay, if that makes any sense to you. I think it will after a while. So when you hear protein synthesis, high mitotic rate, cellular repair, I'm referring to human growth hormone. It's the hormone that's released when you're in passing through different REM cycles in sleep. So, athletes who compete and train, rigorously every day will often take naps in between workouts, have something to eat, take a nap. And in that napping phase while you're sleeping, you're releasing more human growth hormone, which helps all your tissues repair. Okay, antidiuretic hormone. Right. The stimulus is dehydration, maybe decreased blood volume and therefore blood pressure. The production site is the hypothalamus, and it's stored and released, from the posterior pituitary. The target site is the kidneys, and the action response is to increase water reabsorption, increase blood volume, and therefore blood pressure. We looked at some of these hormones, at least in lecture anyway, not necessarily in lab, when we talked about blood pressure, blood vessels, blood, the blood chapter. Disorders, diabetes insipidus, not to be confused with diabetes mellitus. That is an undersecretion or insufficient secretion of antidiuretic hormone. Thus, it produces very dilute urine in the individual. All right, now we're going to move down to the thyroid gland, thyroid and parathyroid. Well, 2 out of 3 of these hormones you're already familiar with because this was covered in EMP1 in the skeletal system, how we're trying to regulate blood calcium levels in the blood. So we have a new hormone, T3, T4, sometimes referred to as is either tetraiodo or triiodothyronine, and sometimes referred to as thyroxine. The stimulus for its release is thyroid stimulating hormone from the anterior pituitary. Right, so we said before, we're going to look at, we looked at what TSH does. It targets the follicular cells. The follicular cells produce T3, T4. Now we're saying, okay, well, the stimulus for the release of that T3, T4 was the thyroid stimulating hormone from the anterior pituitary, right? The production site is the follicular cells of the thyroid gland, right? The target site is essentially all body cells. And the response is to increase ATP production and basal metabolic rate, right? So this affects the efficiency in which your cells can convert different substrates like carbohydrates and fats and proteins to ATP, to energy within the mitochondria, right? You either have a very high metabolic rate or a low metabolic rate or a normal metabolic rate. People with a high metabolic rate burn through food, really quickly. People with a low metabolic rate are generally rather lethargic and they don't convert energy as quickly, and they're very temperature sensitive to cold temperatures. All right, so this is one of the examples of now another hormone stimulates its release, and now we're looking at that particular hormone, T3, T4, and what it does. All right, so we have different disorders. We have cretinism, myxedema, and Graves' disease. Cretinism is hypersecretion of T3, T4 in infants. Mixed edema is hyposecretion of T3, T4, in adults, and Graves' disease is hypersecretion of T3, T4 in adults. Okay, then we go on to calcitonin. Now, calcitonin and parathyroid hormone, these are review hormones. We learned this in AMP1. Right? So the stimulus for calcitonin is an increase in blood calcium levels. The production site are the parafollicular cells in the thyroid gland. We'll look at those slides and I'll distinguish follicular versus parafollicular for you when we get to the images. Right now, we're just filling in the sheet. The target site are osteoclasts in bone, as well as osteoblasts in bone, really. And the action or response is it inhibits the osteoclasts, it stimulates the osteoblasts to increase calcium deposition and store it in bone, and thus we decrease blood calcium levels. So remember, the calcitonin works in opposition to parathyroid hormone. If the calcium levels are already high and osteoclasts break down bone and put calcium in blood, then we certainly want to inhibit the osteoclasts so they don't continue to add more calcium into the blood. Osteoblasts build up bone. So now that we have an abundance of calcium, this is a good time to take as much calcium as possible, store it in bone and make it nice and dense, and then whatever is in excess can be eliminated in urine. And in doing so, we decrease our blood calcium levels back to a normal range. Parathyroid hormone, the stimulus is the decrease in blood calcium levels. Production site is the parathyroid gland. The target site, well, it has multiple sites because it's always more complicated to raise, one of these substances in blood, if we're not taking enough from our diet, than it is to just kind of get rid of our excesses, in the case of how calcitonin is going to function. Okay, so decrease in blood calcium levels. Parathyroid hormone produces the parathyroid gland produces parathyroid hormone. The target sites, multiple sites, osteoclasts in bone, the kidneys, and the intestines. And it targets the intestines indirectly by using calcitriol. Right, so the action response. All right, well, back to the osteoclasts. Now we're going to stimulate the osteoclasts so that they do break down bone, they resorb bone, and they release the minerals like calcium into the blood, and thus, elevating blood calcium. Stimulates the kidneys to reabsorb calcium from the urine that's being produced there. So let's not just pee it away. Stimulates the kidneys to convert vitamin D to calcitriol. And calcitriol targets the small intestine to increase absorption of calcium that's transiting through the small intestine and thus increase blood calcium levels. Okay, now we're going to move on to the adrenal gland that sits at the superior aspect of the kidneys. We have aldosterone and cortisol are the main ones we're going to look at. We also, in a deeper layer of this cortex region, we have some androgens. These are sex hormones, precursors to sex hormones that are produced there. And these two are coming from the adrenal cortex. Then we have the adrenal medulla, which is epinephrine and norepinephrine. Okay, so aldosterone, the stimulus is a decrease in blood pressure, maybe blood volume. It can also be due to hyperkalemia, which is a higher than normal amount of potassium in blood. Production site is the adrenal cortex. The target site is the kidneys. And its action response is to increase reabsorption of sodium. Where sodium goes, chloride goes. And where salt goes, water follows. All right, so we're going to actively pump sodium and start dragging water out of these kidney tubules into the blood system to increase blood volume and therefore blood pressure. All right. As a consequence of that, though, we need to secrete potassium into urine. Thus, if we have too much potassium, what's called hyperkalemic, then we can decrease these plasma levels to a safe range. I think we talked about some of these levels in the cardiac chapter when we talked about, the action potentials, and depolarization, repolarization, the calcium plateau, continued repolarization, and then, you hyperpolarize briefly and you come back to the resting membrane potential. Well, potassium levels, if they're too high or too low or above or below normal, has a potential of either stopping, hyper exciting the heart, which then won't contract again, or depolarizing it so you don't get any heart contractions. Either way, you go into a form of cardiac arrest and cardiac dysfunction, which can lead to death. Right? So, our body is very sensitive to those potassium levels. It's very important to watch those, components of IV solutions and using different diuretics and things with patients, and monitoring plasma levels fairly closely. Okay, so that's aldosterone, right? Cortisol. Right? The stimulus is adrenal corticotropic hormone from the anterior pituitary. So that, we looked at TSH targeting the thyroid gland. So the adrenal corticotropic hormone targets the adrenal cortex to release cortisol, because when cortisol levels are low, or maybe you're in long-term stress, then we want to secrete more cortisol, and ACTH binding to these cells in the adrenal cortex will do that. But now we want to go, okay, let's really look at cortisol a little bit in more detail, because what is its action? Well, the production site is the adrenal cortex. Its target is liver, skeletal muscle, adipose, really all body cells. And its response is going to be very similar to epinephrine and norepinephrine, because those hormones have similar physiological effects, or ways of preparing the body physiologically for fight or flight. And essentially, when you are secreting a lot of cortisol, you're kind of in a prolonged state of sympathetic stimulation, that fight or flight, maybe not full bore like you are in, with a lot of epinephrine and norepinephrine, but it maintains that level. So it's targets the liver, skeletal muscle, all body cells. Action responses to increase blood glucose levels and ATP levels, so because you're anticipating maybe having to use skeletal muscle, and run like hell. And so you're going to have glucose available to convert in the mitochondria to ATP. Has a tendency to inhibit basophils, which can decrease inflammation and thus depress the immune system. It also interacts with or inhibits interleukin-2, which is another chemical that is active in communication and stimulating of the immune system. Cortisol also interferes with and has a tendency to break down some of the connective tissue of ligaments. And so like things like your anterior cruciate ligament, some of the ligaments of your knee, commonly tear due to a lot of the pressure of the femur articulating on the proximal tibia, and those cruciate ligaments keep those two bones together at the knee joint. Well, they have a tendency to sort of break down and fray, and often have torn ACLs in these patients. The action response, we just said that, I beg your pardon. The disorder associated with it is, I believe it's just, let me come back to that just for a second. It's hypersecretion. I just want to finish epinephrine and norepinephrine first, and then I'm going to come back to that because it'll help you tie that together. All right, epinephrine and norepinephrine. All right, the stimulus is a sympathetic nervous system. Remember that a couple, one or two of the thoracolumbar nerves is going to travel to the adrenal medulla, right, to secrete epinephrine and norepinephrine. And that is generally considered short-term stress, in contrast to cortisol, which is considered long-term stress. The production site is the adrenal medulla, right? The target site, multiple target sites, as you know, because you guys study the autonomic nervous system in AMP1. It targets the heart to increase heart rate. It targets the lungs to increase respiratory rates, and the bronchioles to dilate them to allow more air into and out of the air system. It increases blood pressure systemically, and increases blood glucose levels for the same reasons that cortisol did. You want to have enough glucose available to convert to ATP. Okay, then we move on to the pancreas. We have pancreas is a dual function organ. The majority of it has acinar cells that function in the digestive system to produce different enzymes and bicarbonate that are going to be used in the, when we cover the digestive system. But there are other smaller areas, pale staining areas of cells called the islets of Langerhans, or the pancreatic islets now they call that, where we have alpha beta cells, and we actually have some delta cells also that secrete somatostatin. But we primarily look at alphas and betas because they're very active in controlling and regulating blood glucose levels. So the stimulus for the release of insulin is hyperglycemia or higher than normal blood glucose levels. The production site are beta cells of the pancreatic islets, or just the beta cells is fine. The target site is all body cells, liver, and skeletal muscles. So picture it this way, you have excess glucose, right? You need to essentially ring the dinner bell for all your body cells to start taking up that glucose and storing some of it, because it's going to need it in the mitochondria along with oxygen to convert it to ATP for active mechanisms that are occurring in that cell. Right? So we want to let, signal all body cells, to start taking up insulin. And when that is completed, then whatever is in excess, right, is going to be repackaged from the monomers of glucose to the polysaccharide of glycogen and stored in the liver and in skeletal muscles to be used later. Right? Anything in excess of that will essentially, and we'll talk about that in lecture in one of the last chapters, will be converted to fat. So the action response is to increase glucose uptake into the body cells, stimulate the liver and muscle to form and store glycogen, and thereby, or thus, decrease blood glucose levels, hopefully back to a normal range. We have two disorders. We have diabetes mellitus, so DM1, and we have DM2. DM1 is an autoimmune disorder, usually juvenile onset, that will generally be and is insulin dependent. The degree of insulin you'll need depends on, how extraordinary the extent of DM1 is. Do you have any beta cells? How many beta cells, producing some insulin, but a lot of those beta cells, will not produce any insulin. So you're going to have to supplement that. Diabetes mellitus 2 is generally an adult onset or secondary to something else. And DM2 in most adults is due to very long years and years of eating a poor, like a poor carbohydrate diet, and not eating enough fruits and vegetables and proteins. So, or appropriate fruits and vegetables, I should say, and proteins, because all fruits and vegetables, as well as rice, potatoes, well, that's a vegetable, rice, sugars, that we eat in cookies and cakes and things, they're all carbohydrates, but they don't all break down as quickly as others. And that refers to the glycemic index. A high glycemic index means that they break down very rapidly and elevate, blood glucose levels very rapidly in your blood. All right. So I don't want to put all fruits and vegetables into that category, but most fruits have a lot of sugar in them. So they're not necessarily bad for you because you have vitamins and minerals associated with these, but you want to balance, your food sources. And because they generally have fiber in them, they have some other kind of nutritional, benefit. But when you eat a lot of donuts and processed food and breads and pastas, and I love those things, they have a tendency to keep elevating your blood glucose levels over and over again, all day. And over years, you start to burn out those beta cells, and they start to, become dysfunctional and die off. In addition to that, often the receptors on your body cells start to downregulate, and because there's been too much glucose in the cells. And once they downregulate those receptors on the surface of their cells for insulin, then after a while, the glucose levels drop in the cells, and it takes them time to put up more receptors on the surface. And so the cells kind of start to starve, and not have as much energy for active processes in the cells. So in doing so, right, high carbohydrate, high sugar diets end up kind of killing off those beta cells and interfering with the receptors on your other body cells. And both of those start to then allow blood glucose levels to remain elevated for longer period of time than they ever should be. Elevated blood glucose levels are very harmful after years, in your body. It doesn't even have to be a super high level. It's just the duration of time, so to speak. It can affect the retinas, and affect vision. And, it affects your ability to certain areas of the skin, especially in the hands and the feet and the legs, to the skin to repair properly. There's all these different issues associated with nerve dysfunctions called peripheral and distal neuralgias. So that's diabetes 1, diabetes 2. Diabetes 1 is generally an autoimmune disorder where it's juvenile and even infant onset, where it's insulin dependent. And diabetes 2 is generally secondary to something else later in life. There are exceptions to that, of course, but that's generally the etiologies of those two. All right, glucagon. Right? The stimulus is hypoglycemia, or low blood glucose levels. Right? The production side of the alpha cells, the pancreatic islets, or the islets of Langerhans, or just the alpha cells. The target is the liver, primarily. And the action response is to increase the carbohydrate and lipid breakdown and increase blood glucose levels. All right, so what does that mean? It means that glucagon is going to go back to the liver, where we stored our excess carbohydrates or glucose as glycogen when we used insulin. Now our levels fall too low and we want to take it back. And essentially, you're going to break down that glycogen and quickly elevate glucose levels. When you start getting to the end of that, then you start stimulating the breakdown of fats, and thereby elevate blood glucose levels back to a normal range. But, even though it'll say in there, it stimulates carbohydrate and lipid breakdown, and it does, but it'll go to the carbohydrates first because it's easier. I mean, I think we all know, well, for any of us to try to lose weight, that had to lose weight, you exercise generally. It doesn't have to be, you have to run for 20 minutes, 30 minutes to start burning fat, but you have to have at least a low level, a moderate level of activity. And the first 20, 30 minutes or so is generally using up a lot of your carbohydrate stores, your glycogen stores. And then you start doing the slow fat burning, at that point. So that's how those coordinate. Okay, in this page, that is the end of the negative feedback loops. Here is some test your knowledge. You can match up your hormones to the production sites, and we'll go through these. And then we'll look at some of the notes maybe. I'm going to stop this momentarily and then open up another portion of the Zoom for those who just want to fill this out first. And then we're going to go back and look at the different images and whatnot. The thyroid gland and the parafollicular cells, they produce the calcitonin. Adrenal cortex, well, we have cortisol and aldosterone from there. The posterior pituitary gland, or referred to as the neurohypophysis, stores and releases OT, oxytocin, and antidiuretic. The alpha cells of the pancreas produce glucagon. The follicular cells of the thyroid gland, produce T3, T4. The adrenal medulla releases epinephrine and norepinephrine, produces and releases epinephrine and norepinephrine. Anterior pituitary gland, 6 hormones, but the 3 we're looking at now are human growth hormone, TSH, and ACTH. The beta cells of the pancreas produce insulin. Parathyroid gland produces parathyroid hormone. And then we go on to now matching up the hormones to some of the functions or the actions. All right, so this is where I try to be a little, give you little key terms. And what I might do is circle some of these key terms so that you can, when you go to study, is repeat that term kind of over and over and start to associate it with a particular hormone. Okay, So number one, increase glucose uptake into body cells to decrease blood glucose levels. That would be insulin. Increases heart rate, dilates the bronchioles, constricts arterioles, increase blood glucose levels. That would be epinephrine and norepinephrine. 3, stimulates osteoclast activity to release calcium from bone, stimulates the kidneys to reabsorb calcium, blah, blah, blah. It increases blood calcium levels. This parathyroid hormone. 4, stimulates cortisol release from the adrenal cortex. That's its only function, ACTH. 5, increases blood glucose and ATP levels, inhibits basophils, which increase inflammation and depresses the immune system. Right, that's cortisol. 6, increase water reabsorption into the blood to increase blood volume and blood pressure. Water alone, antidiuretic hormone. 7, stimulates T3, T4 release, thyroid stimulating hormone or TSH. 8, inhibits osteoclast activity, increases calcium deposition. So I'm decreasing the blood calcium levels, right? That would be calcitonin. 9, increases reabsorption of sodium and water into the blood to increase blood volume and blood pressure and secretes potassium. That's aldosterone. 10, increases ATP production and increases the basal metabolic rate. That's T3, T4. Increases mitosis rate, increased protein synthesis, cellular repair, human growth hormone. And 12, increases carbohydrate breakdown to increase blood glucose levels. That would be glucagon. Okay, so the ones that have some key terms, I would say are, 5, when you increase blood glucose, inhibit basophils, decrease inflammation, depress immune system. Right? You really want to keep that connected to cortisol. And this is why people say, like, well, if you're under a lot of stress, you're more likely to get a cold or a flu. It could cause you to get sick. Well, really, the only thing that causes you to get sick is a virus or a bacteria. But I will say, however, is that you are more susceptible. Your immune system can be depressed and inhibited, when you're under a lot of stress and you're releasing a lot of cortisol. Increase water absorption alone at the kidneys, antidiuretic. Increase sodium absorption and thus water, and secrete potassium, aldosterone. Right? Increase basal metabolic rate, increase ATP production. Right? That's T3, T4. So metabolic rate versus 11, mitosis rate, protein synthesis, cellular repair, human growth hormone. Hormones, they have a lot of overlapping function with other hormones, or they seem to anyway. I mean, the stimulus for the release is always unique, but, some of these hormones, because they are in the steroidal family of hormones, is they affect multiple, areas of the body, or, and cells throughout the body. And so when they're targeting, if they're capable of targeting the liver, then they're capable of elevating blood glucose levels. And, it gets a little bit confusing, but I will try to limit certain terms like that to certain hormones. When you read through the textbook, you can clearly see how complicated it is. We're not here to make your life miserable, but as long as you can have a certain amount of knowledge about how these hormones function a little bit differently, under different circumstances. Okay, so let me stop my share right now, and then I will reopen another Zoom so we can look at the images and maybe some of the notes.